Assalamu alaikum. Here we will discuss female urinary incontinence. We start with the content of our lecture. We start with the definition, normal continence, physiology of normal continence, impact of incontinence in life, symptoms and etiology of female urinary incontinence, pathophysiology of female urinary incontinence, prevention of the condition, diagnostic approach, non-surgical management and surgical management, and lastly, the conclusion. We start with definition. The definition of urinary incontinence is a condition in which involuntary loss of urine is a social or hygienic problem and is objectively demonstrable. This is the International Continence Society definition in 2020. The complaint of any involuntary leakage of urine is incontinence. Stress urinary incontinence, which is a type and the most common type of female urinary incontinence, is also known as effort incontinence and is defined as a form of urinary incontinence that is caused by stress and increased intra-abdominal pressure. It is due to insufficient strength of the closure of the bladder, as we will see later. The normal continence society is simply due to three main factors. The first is the lining epithelium of the urethra. The second is the bladder neck positioning and attachment. And the third is the external urethral sphincter. So we have three main factors to cause continence, urinary continence in female. The first is the lining of the urethra. The second is the position of the bladder neck, and the third is the urethral sphincter muscles. We should know that the functional urethra is intra-abdominal organ. Functional urethra is intra-abdominal organ. Increased intra-abdominal pressure is transmitted equally to the bladder and urethra, equally from all sides, because the bladder and urethra, functional urethra, are intra-abdominal organs. So the intra-abdominal pressure is transmitted equally to the bladder and the urethra. With increased stress, the urethrovesical junction respond to stress by closing tight. This is the urethrovesical junction. It responds to increased intra-abdominal pressure by closing tightly. And we mentioned before, the closing mechanism depends on the lining epithelium of the urethra, intact lining epithelium of the urethra, the angulation between the bladder in the bladder neck, between the urethra and the bladder and the urethral sphincter, or sphincter muscle. Bladder is a voluntary smooth muscle, which is the detrusor muscle here. Inherent ability to maintain low pressure with filling increase in compliance. The bladder muscle relaxes during the filling phase, and the relaxation of the detrusor muscle lowers the intravesical pressure, and so gives more compliance of the bladder to be filled with urine coming from the ureters. The impact of urinary incontinence on the female's health. Urinary incontinence is not associated with increased mortality. However, incontinence can impact many other aspects of patients' health, such as the quality of life. Urinary incontinence is associated with depression and anxiety, work impairment, and social isolation. Sexual dysfunction. Incontinence during sexual activity, what's called coital incontinence, which may affect up to 1/3 of all incontinent females, and fear of incontinence during sexual intercourse, both contribute to incontinence-related sexual dysfunction. Morbidity. The morbidity due to urinary incontinence includes perennial infections due to candida or cellulitis from moisture and irritation, as well as fall and fractures that in turn increase overall morbidity of the female complaining of urinary incontinence, and also increases the healthcare costs, especially in the senior females. Increased caregiver burden. The health care costs increases, and the burden of caregiver. So about 6 to 10% of nursing home admissions in the United States are attributable to urinary incontinence. What are the causes of urinary incontinence? Causes, as the diagram shows, may be stress, urinary incontinence due to stress, and this is the most common cause and most common type of female urinary incontinence is stress urinary incontinence. Constitutes about 50% of cases of female urinary incontinence. Overactive bladder syndrome, and also simply known as urge incontinence, constitutes about one quarter of cases of urinary female incontinence. Or mixed urge and stress incontinence. Overflow incontinence in urogenic bladder, when there is a urogenic deficit, overflow incontinence. So these are the four major types of female urinary incontinence: stress incontinence, urge incontinence, mixed incontinence, and overflow incontinence or neurogenic bladder. Other types of incontinence, such as genitourinary fistulas, and this is a total incontinence. Urethral diverticulum. Functional incontinence, such as bedridden patients for long periods will develop functional incontinence. Reversible causes due to the most common cause of reversible incontinence is pregnancy. So you cannot evaluate a patient with stress incontinence while she is pregnant, because this is a temporary condition. What is the prevalence of female urinary incontinence? Overall prevalence of urinary incontinence ranges widely in literature from 5 to 50%, and this is a wide range, and this may be non-specific or non-specification of the type of incontinence during estimation of the prevalence, or inconsistency of the studies, or differences the different locations. Stress urinary incontinence is most common type of urinary incontinence, as we previously said, and constitutes 1/2 of cases, followed by urge, and lastly the mixed type. Overflow incontinence, urinary fistulas, urethral diverticulum, functional incontinence, and reversible causes of incontinence are uncommon causes of urinary incontinence, as we previously said. We come to the types of incontinence in diagrams. This is the normal bladder. When the bladder is full, the continence mechanism of the urethra is complete. So the urethral closing pressure should exceed the intravesical pressure for continence to occur. If this mechanism, the urethral closure pressure, does not exceed, becomes less than the intravesical pressure, as in cases of urge, there is a dribbling before the patient reaches the toilet. Or this pie shows the types, the percentage of the types of female urinary incontinence, and as we can see the main part of the pie is related to the stress urinary incontinence. The second is the mixed urinary incontinence, and the third is the urge incontinence. We come to the stress urinary incontinence, which is the most common type of female urinary incontinence. Stress urinary incontinence is defined by the International Incontinence Society as the complaint of involuntary leakage of urine on effort or exertion or sneezing or coughing. Genuine stress urinary incontinence, urinary loss, which occurs with sudden elevation of increased intra-abdominal pressure without detrusor contraction. Detrusor contraction should be excluded when the diagnosis is stress urinary incontinence. The symptoms of stress urinary incontinence include involuntary leakage of urine on effort or exertion or on sneezing or coughing. Usually small amounts, spurts. Pressure in the bladder exceeds the urethral closure pressure. No bladder contractions. The the trouser does not contract. If contracts, it is not pure or genuine stress incontinence. What about the etiology of genuine stress incontinence? Childbirth and pregnancy are causes of stress urinary incontinence. So, stress incontinence is not diagnosed while or not evaluated while the patient is pregnant or recently delivered. The second is age. Stress urinary incontinence is a condition of senior females. Obesity, especially when there is a morbid obesity and BMI is more than 40. In such population, more than 60% of them complains of some degree of stress urinary incontinence. Chronic increased intra-abdominal pressure, chronic cough, genital prolapse, especially anterior vaginal wall prolapse, with hypermobile urethra and detachment of the bladder neck is a cause of stress urinary incontinence. Constipation due to straining during defecation that increase intra-abdominal pressure chronically. Smoking is a predisposing factor for stress urinary incontinence. Some genetic predisposition are suggested. Other causes or other risk factors for stress urinary incontinence include cognitive impairment, mobility impairment, and anatomical abnormalities in the genitourinary system. We come to the types, etiologic types of stress urinary incontinence. We have only 3 types. Type 1, in which the stress incontinence is due to posterior urethrovesical angle alone. Loss of posterior urethrovesical angle alone. If a patient has loss of the posterior urethrovesical angle plus urethral hypermobility, this is a type 2 stress urinary incontinence. However, if the defect is intrinsic in the urethral sphincter, what's called intrinsic sphincteric deficiency, the type is 3. So we have 3 main types of stress incontinence. Type 1, due to loss of posterior urethrovesical angle. Type 2, loss of posterior urethrovesical angle plus urethral hypermobility. And type 3, due to intrinsic sphincteric deficiency. The pathophysiology of stress incontinence is divided theories explaining pathophysiology of stress urinary incontinence are divided into main 2 theories. One theory to explain the intrinsic sphincteric deficiency, and the other is explaining the detachment of the bladder neck and hypermobility of the bladder, what's called the Hammock theory of Delancey. We start with the first theory that explains sphincteric dysfunction. This theory explores the condition of intrinsic sphincteric deficiency. In this condition, the urethral sphincter is unable to generate enough resistance to retain urine in the bladder, especially when the intra-abdominal or intravesical pressure is increased. This intrinsic weakness or deficiency may be due to, or may be as a result of, congenital defect such as CNS deficiencies or dysfunctions or lesions, smooth muscle disorders, striated muscle disorders and may be acquired, such as due to childbirth, due to overstretch of the urethra and injury of the sphincter, surgical therapy or surgical treatment or surgical operations or surgical trauma in such vicinity, radiation trauma, CNS lesions, transection of the cord, peripheral neuropathies, and coronary catheter drainage. Other causes are attributed to hypoestrogenism and aging process. The second theory that explains the continent mechanism due to the pubocervical fascia. Pubocervical fascia. This theory is supposed by Delancey in 1996, proposed a consolidation or consolidated theory. He hypothesized that the pubocervical fascia provides a hammock like support for the vesical neck and thereby creates a backboard for the compression of the proximal urethra during increased intra-abdominal pressure. If this hammock is defective, this backboard is deficient, and so the urethra is hypermobile and incontinence occurs. This is another diagram for the hammock theory. This is the continence zone, which is supported by the pubocervical. How to diagnose stress urinary incontinence? The primary goals of evaluation of women who presented with symptoms of stress urinary incontinence are to provide a clinical diagnosis of stress incontinence and differentiate it from overactive bladder condition, to determine factors that may contribute to symptoms or that may require further evaluation, to assess whether coexisting pelvic floor disorders such as pelvic organ prolapse or anal incontinence are present, to establish baseline stress urinary incontinence severity to aid in assessing treatment effects, to determine the impact of patient symptoms on her quality of life, to determine which treatment options are acceptable to each patient, to determine what her own therapeutic goals are, and to provide her with appropriate education regarding these goals, which are chosen by her. The diagnosis passes through these steps: careful history taking, physical examination, voiding diary, and finally simple tests for diagnosis of stress incontinence. We start with the basic history. We should ask about frequency of leakage and amount of leakage, participating factors such as risk factors we have discussed before, impact of the leakage on her quality of life, pelvic floor symptoms such as sensation of bulge or pressure in the vagina, urinary urgency or frequency, nocturia, hematuria, recurrent urinary tract infections, voiding problems, anal incontinence, and defecating difficulties or dysfunction. We come to physical examination. Basic physical examination includes pelvic examination to rule out pelvic or abdominal masses, pelvic organ prolapse, and vaginal atrophy. A positive cough test in which leakage is visualized at the moment of cough is helpful to confirm the diagnosis. the patient lies in a dorsal position, vulva is separated, and bladder is half full, and the patient is asked to cough. In positive cases, there is a spurt of urine seen running out of the external urethral meatus. On vaginal or rectal examination, we should check the pelvic floor muscles quality regarding symmetry of the muscles and the bulk of the muscle, and whether or not and to what extent a woman can volitionally contract herself. As a conclusion, or to complete the physical examination, the cotton swab test should be done. In the upper two diagrams, this is the normal condition. This is the resting condition. This is the angle. And when the patient strains, the urethra is elevated to this degree. If the patient have incontinence, stress incontinence, there is a much mobile urethra, such as shown in the diagram. To rule out urinary retention and overflow, the post-void residual volume must be estimated. We can estimate it by direct catheterization or by ultrasound evaluation. The normal is less than 50 milliliter. If it reaches 200 milliliter, this is actually abnormal post-void volume. Finally, urine analysis must be done in each case to exclude the urinary tract infection as a transient cause of stress incontinence. We come to management of stress incontinence. Women have both non-surgical and surgical options. Not all women with stress incontinence will need surgery. Some factors should be considered before deciding whether to undergo surgery or not. These factors include the severity of stress urinary incontinence symptoms and their effect on daily activities, the desire for future pregnancy, because pregnancy and childbirth may cause recurrence of stress incontinence in a successfully surgically treated patient. The management are either non-surgical or surgical. The non-surgical management include lifestyle interventions, pelvic floor training, medications, and certain devices. The surgical management include use of injectable bulking agents, laparoscopic suspensions, mid-urethral slings, pubovaginal slings, and open retropubic suspensions. These 5 options, surgical options, are suggested by the American Urology Association for surgical management of stress urinary incontinence in females. We start with the non-surgical treatments, starting with the lifestyle interventions, including weight reduction, postural changes, such as crossing the legs that may help to control the leakage, fluid intake and voiding habits. Decreasing the fluid intake is helpful in women with high fluid consumption, and voiding prior to strenuous activity is beneficial also to prevent mild urinary incontinence. Pelvic floor exercises, supervised pelvic floor muscle training, Kegel's exercises, is an effective treatment for stress urinary incontinence, should be offered as a first-line conservative management for women with stress incontinence. Several factors are important in maximizing the effect and maximizing the benefit of this pelvic muscle training. These include, the woman must do the exercises correctly, regularly, and for adequate period of time. Many physical therapists recommend training sessions 3 to 4 times per week for 3 repetitions, with 3 repetitions of 8 to 10 sustained contractions each time. We come to medications. The first medication is estrogen. Estrogen has a topical effect on urethral epithelium, subepithelial vascular plexus, and connective tissue. Studies showed improvement of symptoms but not aerodynamic measurements. Alpha adrenoreceptor agonists as ephedrine, norepinephrine, or norepinephrine, and midodrine have shown only modest effect in small trials. Serotonin and norepinephrine reuptake inhibitors. Duloxetine is the most common drug used and is effective in treatment of stress urinary incontinence. We come to devices. Ring pessary compresses the urethra against the symphysis pubis and elevates the bladder neck. Of course, this is effective in type 1 and type 2 stress urinary incontinence, and not the type 3 in which there is intrinsic sphincteric deficiency and no mobilization, hypermobility of the bladder neck or the urethra. For some women, this may reduce stress incontinence. Minimal invasive surgical techniques for women in whom Kegel exercises are ineffective and who desire definitive surgery. 5 procedures are endorsed by the American Urological Society, as we mentioned before. These include use of injectable bulking agent around the urethra, laparoscopic suspensions, laparoscopic perch, for example, mid-urethral slings, TVT or TOT, tension vaginal tape or transobturator tape, pubovaginal slings, open retropubic suspensions. We come to the conclusion of our lecture. Stress and urinary incontinence is common in women and may impact their activity of life and level of activity and the quality of life. Conservative management should be preceding the surgery. We should try conservative management before resulting to surgery in each case. Minimal invasive treatment measures can readily be initiated by primary care provider with referral to specialist when conservative management is not effective. Many gaps remain in our knowledge of this disorder, stress urinary incontinence. Further research is also needed to study prevention of the leakage, factors that impact treatment success and longevity of various therapies. New therapies should be studied in randomized clinical trials before general or clinical use. We come to the end of our lecture. I thank you very much for your attention and your concern. Thank you very much.